Yes, I love that idea. Thank you. Jane, will you get us started? Wonderful. All right. Well, good morning, everybody. And I love the chat. I love seeing where everyone's from, and just in case there's someone I haven't met yet. And I hope you enjoy that too. Good morning. My name's Nancy Frank Wilson. I'm the Executive Director of the Minnesota Oral Health Coalition. Just honored to be with you this morning. Thank you so much. We've got another 2 hours of just very interesting and informative and exciting presentations. And before we do, we'll just do a little bit of housekeeping. As Jane said, please put your name and where you're from, what you do in the chat. We're here until 11. Take your break as you need it. We won't do any organized breaks. We are recording. This will end up on our YouTube channel. And if you haven't been there, it's really full of amazing resources for you. We will make CEUs available. We've asked all of our presenters from Monday, today, and tomorrow to share their materials. So I'll be sending out a link to probably a Dropbox that everyone can access with our materials in there. And yeah, so for those of you in Minnesota, welcome, and hope the snow is not too much of a problem. And we do have friends from around the country, so welcome to you, and I'm really happy you could join us. So we're going to start this morning with Dr. Prashita Kanal and Jeremy Van, integrating oral health into the whole school, whole community, whole child, the WSCC model to advance health equity. Take it away, you two.
So Jeremy is going first, Nancy. So I will take over.
Yeah. So good morning, everyone, and appreciate the opportunity to present to you today. Let me get my slides going, and hopefully that'll work. If I can maybe get a thumbs up. Okay, perfect. So again, so I'm going to focus on the statewide health improvement partnerships role in oral health. And so from now on, I'll say SHIP, but when I say SHIP, I'm referring to the statewide health improvement partnership. And just real briefly, yeah, I'm with the Minnesota Department of Health. I'm the school health services coordinator. Been with the department for almost 4 years. Prior to that, I was with the Carver County Public Health. I was a SHIP specialist there. Have worked in school settings in a variety of roles. Previously was at Denver Public Schools, the school wellness specialist. And I'm also a returned Peace Corps volunteer, as a little fun note. I appreciate the collaborations, and that's really what SHIP is all about. This will apply a little bit more to those in Minnesota than those out, but hopefully it is still a good opportunity to learn. So just briefly then, I'm going to describe the Statewide Health Improvement Partnership for those who maybe are unaware, and there's a lot of new faces in the room today for me, so maybe some haven't heard of SHIP. I'm going to dive a little deeper into what is the whole school, whole community, whole child model, or WISC. Also, when I say WISC, I'm referring to that. And then I'm going to highlight how SHIP can work with schools on oral health. And I'm also going to just highlight the partnership that we have with our oral health partners, and Prashita and some of her colleagues as well, and really benefit and value that partnership. So briefly here, and as Nancy was saying, you'll have the slides, and so you'll have this link. But this is just where the landing page is for SHIP. And this is a primary prevention chronic disease strategy. It is in state statute for Minnesota, and it works with or funds all 87 Minnesota counties, as well as 10 of the 11, if I'm not mistaken, tribal nations. So this is across the state. It is organized typically by the Community Health Board. And so there might be a CHB that works with multiple counties. But that said, all across the state, you have a SHIP coordinator in your region. And traditionally, we've really focused on active living, healthy eating, commercial tobacco-free living. But through work through the CDC, we have also really focused on, chronic students with chronic conditions. So asthma, diabetes, seizure and epilepsy and other disorders, as well as oral health challenges. And so that's where the partnership comes into play. I wanted to highlight as well that then local SHIP staff, so again, I'm at the state level with MDH, and I support that local public health that works with school partners in their communities. So local SHIP staff do receive funding and are mandated through that state statute to work with school partners. And just a little sense of the scope from 2019 to 2021, local SHIP staff worked with over at 926 different school sites. Well, that level of partnership varies, but hopefully demonstrates really kind of that reach. And I do want to highlight that while local SHIP have the autonomy to select their local priorities, in my role and with our partnership with other MDH programs, such as our oral health program, this is where I can kind of direct their work and identify where they can bring in some additional partnerships, how they can support their school partners. And so really part of local public health's role is to find those connections and to support schools. And so making the connection to our oral health partners is one of those roles that they can fill. Broadly speaking, our SHIP school staff work under the CDC Healthy Schools program, and that link is there. You can review it more when you get a chance. And again, they're tasked with building that support in their school buildings or with their school partners. We do look to establish a school wellness team. Could be a district wellness committee. That title can vary, but broadly speaking, school wellness team. And again, tying in those community partners. And that could be any sort of community clinic linkage. That could be oral health partners, as I mentioned, other partners as well too, but today as we're thinking about those oral health partnerships, they're also focused with conducting an assessment and reviewing the school wellness policy and the school wellness environment. And so that could be identifying where maybe there's some areas of growth, which could be within broadly school health services. And then again, utilizing that whole school, whole community, whole child model, which, diving into that a little deeper, is all about that collaboration. It's all about that looking at things holistically and comprehensively. And I have a model here. And I think Prashida might discuss this a little bit as well, but just to identify, this is a student-centered approach that really thinks about the student's needs. And the focus is that alignment, that integration, that overall holistic approach to make sure that students are healthy, safe, engaged, supported, and challenged. And in our role, a lot of times we're focusing on that healthy piece, but maybe there's other aspects. And so utilizing this model, this is where we can say, sure, maybe you're working on a healthy eating activity, but let's bring in that health services. Let's bring in that oral health piece too. And that's that emphasis on the role of the community. And that community can vary, can encompass a lot of different partners, and medical partners and oral health partners could be one such partner as part of that community. And you can kind of see here the different components with health education, physical activity, nutrition. I'm not going to break these down because we could have a whole webinar just on that or a presentation just on that. But I encourage you to kind of explore that and identify where you might see yourself fitting within this model to, again, support students. And the nice thing is that this model is recognized by organizations across the country. And so here you have ASTDD's recommendations here and how they try to demonstrate how the WSC model can be used for oral health integration and provide some recommendations. I'll get to make sure you have that link, or you could just search ASTDD best practice committee for WSC model, and this will pop up. And you can kind of see here, they start with health education. They identify what that would mean for oral health. They move to physical education and activity, what that would incorporate, and go from there. And the thing is with this WSC model is oral health could be the center. It could be the focus. And that's great. And you could have a lot of different activities looking at how to support students in oral health. But where I come from and how I think what I'm trying to encourage you today, and as I work with our local public health, is to say that we're working on other projects that could connect to oral health. We do a lot with vaping and vaping prevention. We could tie in oral health to that. As I mentioned before, we do a lot with healthy eating. Great opportunities to bring in oral health to that. Broadly with the wellness policy, school health services. If there's ways to make things more comprehensive and bring in oral health into those other activities, that's where I think there can be a lot of success. Again, it can focus right on oral health, or there's the other aspects too. So thinking about school health services broadly, I'll kind of let you read through these activities, but in general, we can include supporting students with oral health through our school health services work broadly. So you can kind of see there, plan and develop a coordinated system to meet the needs. That could be identifying oral health partners, or establishing community clinic linkages, or working with varnish or sealant providers to access students there. You'll see other things like provide specific age-appropriate education. That could be have an oral health aspect to it, the professional developments, and some other things there maybe don't apply quite as much, but these overall systems can really support that work. And so just to highlight, within our SHIP guides and documentation, we have indicated to local SHIP staff that they can work on school health services to support students with chronic conditions such as asthma, disordered eating, oral health, and we have a number of others as well too. And so you can see that this is one activity that they can select to work on. So it is something that local public health in your area have knowledge of, could be working on, and maybe this is a new activity, so maybe they're still getting started with it, but it is something where they can work on that. And to highlight that, some have already started that work. One was broadly in their wellness policy. And this is from the school district up there, you can see in the corner. And I kind of pulled out the language, but they, because I just took a screenshot, so you can't see it there on the right, but down in section F, which I have on the left, they have language to indicate that oral health is essential to general health and well-being. And they talk about why they need to work on this and why it's important. And that's a kind of small language, but the fact that it's part of a wellness policy is essential to say, hey, we need to work on this. And then that's where, again, with Prashida and our oral health team, that's where we can start making those connections and start saying, hey, if this is part of your wellness policy, now let's connect you with those varnish or sealant providers. Here you'll see from a work plan, this was up in the Healthy Northland area, the northeast part of the state. Within this Greenway School District, they're looking to develop these community clinic linkages to support students and services, broadly speaking. So that community clinic linkage could be for oral health or with oral health providers. So no, that was really brief. Going to be sticking around as Prashida continues to speak about this partnership and how we work together. So I think we'll leave the questions till the end, but please think about those. I'll be writing in the chat, and yeah, I'm hoping that we could look to see how those partnerships could exist.
Thank you, Jeremy. I'll just try pulling my slides. Jeremy, are you able to view my slide?
It just popped up. Yep, all good.
Okay. Good morning, everyone. Thank you, Jeremy, for your wonderful presentation. Again, for those of you who do not know me, my name is Prashila Kanal. I serve as the State Oral Health Director at Minnesota Department of Health, and our work is possible because of partners like Minnesota Oral Health Coalition, our Sealant grantees, and a lot of other partners who have really helped us advance the medical dental integration conversation. So today I'm going to focus my presentation to talk about how we can actually integrate oral health into the WSCC model that Jeremy just mentioned. And the reason why we want to do this is to advance equity. So I wanted to start with this picture because I feel like this picture has changed the way I look at dental public health planning and policy. So that's me in the picture. So this was probably 10 years now, while I was still working in Nepal as a community dentist. So I was serving many underserved areas, and I would travel to go to villages to make sure that people were getting care. So this picture talks about a lot of hope. It also talks about helplessness, right, as a provider. So the story is really like this boy came to the dental camp, and for those of you who are not familiar with how things operate in low-income or developing countries, communities tend to depend on the free dental camps for their access to dental care, right? So it was one of those dental camps where I was the provider, and this little boy already had a tooth infection, and there was also an abscess, and I did not have resources to save the tooth. So the only option I had was to pull out a permanent molar. And then that's why I'm looking at this boy because I was helpless. And this boy, I still remember his looks, and he's looking at me with so much hope. And then there is his mom thinking that, oh, we have provider once in a while in our village, and this is the time the tooth has to be pulled. Because if I didn't pull the tooth that day, this family would have to travel for at least a day and a half to reach to a primary care center. And again, they would be referred to a dental facility. So I ended up really pulling out the tooth for this little boy. So at that time, as a young dentist, I did know that everybody deserved to be healthy, and everybody deserved to have a healthy mind, healthy mouth, and also a healthy body. But I did not know that when I was talking about everyone, that health equity must be a priority. So fast forward to coming to the US 10 years back, and I came here with American Dream, thinking that all cities looked like New York City, and I felt everybody had a car, everybody could speak in English. But then once I started to volunteer, I realized that I was the one handing out bus passes to families so that they could bring their children into the free care or subsidized care. I was also serving as interpreter for some families, and it was also really confusing to me not to see our families show up even if the care was free. So I didn't understand what was happening. So, and then over the course of my volunteer work, and the more I worked in the US, I did feel that the mouth was not part of the body, something that Mary Otto so beautifully described in her book, The Teeth. And she also talks about how in the US specifically, we treat the mouth separate from the body, but because our body didn't sign on for this arrangement, right? And teeth don't know that they are supposed to keep their problems confined to the mouth. And this separation leads to real consequences. And many of you have already heard about DeMonte Driver, a 12-year-old boy from Maryland who had a tooth abscess. And because his family didn't have dental insurance, he ended up getting infection, which went up to his brain. And he was taken to the hospital for a brain surgery, which was not enough to save him. So what I'm trying to tell here is that a $1 fluoride or a dental sealant could have prevented the infection or abscess to begin with. So recently, I had the opportunity to attend the Minnesota School Nurses Association conference, and I did get an opportunity to talk to many nurses about school nurses about what they are seeing in the school. So before I tell you what I learned from them, I wanted to ask you this question about what kind of dental issues are you seeing in schools, whether you are a dental provider, you are a school nurse, you are a medical partner working in school, or even as a family, you might have heard of many things happening in the school. So if you can unmute yourself or put something in the chat, I would totally appreciate that. And maybe Nancy, you could monitor the chat for me to see if there are some responses coming in.
Absolutely.
Mhm.
So do you want to ask your question one more time? What would you like people to
So
put
what kind of dental issues have they come across in schools?
Okay, thanks.
I can say something. And what I've seen is that a lot of teachers have reached out to me for students in their classroom and their corresponding families to help find dental providers. There's no providers that are taking new MA patients in my region. So a lot of families are having to go to the Twin Cities to get services, and it's been really hard, like with transportation needs. That's a big need in our community. And just having it not be a priority, and just that education piece for parents too, to know where they can go and why it's so important for them to bring their kids in regularly.
Right. Thank you, Alexis. I think you summarized everything that I heard from the school nurses. But something that was really disturbing to even hear, which broke my heart, was a couple of stories. One of the nurses, she stopped by the booth we had, and she looked at this little model here that shows the progression of tooth decay. And she said, oh, if our kids are lucky, they will come to me with this particular stage. So this is already the advanced tooth decay stage, where you see a lot of enamel surfaces, or the tooth has already been decayed. But what she told me was, most of the times when school nurses are even seeing these children come to their office, either they already have abscess or more infection. And the other story I heard was, so many of our children are forced to be on prolonged medication, like over-the-counter medication or painkillers, so that because there is no access to the provider, right? So those things are really concerning when you're looking at it from the equity point of view. And these things are more concerning in oral health, because most of our dental conditions, especially if you're looking at tooth decay, that is one of the most important or challenging disease we have, is preventable with education and different hygiene skills. So that is the reason why, starting from Nepal, where I thought everybody deserved to be healthy, and I didn't know, oh, we have to prioritize equity if you're talking about everyone, to coming to the US and seeing the divide between the mouth and the body, and hearing all these things from partners and school nurses. I think today I'm here to basically ask you this question: where do we go from here? So that is the reason why I have very specific objectives for today's presentation. One is to, again, reinforce the importance of oral health for school readiness. Second is really look at the data to show how much disparities are we seeing? What are the equity issues when we talk about our children in school? Jeremy has already talked about the WSCC model, the core of it. I'm going to talk about how can we take oral health and put it into the WSCC model, so then we have true medical dental integration. I will also talk about the rational and practical strategies to integrate oral health into the WSCC models, knowing that our schools have capacity issues, knowing that our school nurses are already maxed out, so still are there opportunities for us to move forward, and then talk about some resources that might be helpful. So talking about oral health and school readiness, dental health plays a key role in overall health status and quality of life of children. Dental health may also affect several domains of child development and growth. The benefits of maintaining good health extend far beyond just our mouth. In fact, our oral health, the health of our teeth and gums, has a major impact on overall health, medical cost, and quality of life. Good oral health enhances a child's ability to develop several physical and social functions, such as feeding, breathing, speaking, smiling, and social adaptation. So when we talk about dental condition, it's important to understand that plaque is a colorless film that's formed in our teeth, as you can see in these images. And this can be removed with simple brushing and flossing, or by visiting a dental provider on a regular basis. But then if a plaque stays back in our mouth, it hardens into calculus, or something we call like tartar, and that is the root cause of all the dental conditions, such as gum disease or cavities that we see. So healthy children are also more ready to learn, because The consequences of dental diseases in children may include pain, discomfort, embarrassment, challenged cognitive development, reduced self-esteem, and impairments of daily life activities. And the health of child's mouth can affect their overall health and well-being, learning, and ability to succeed in school. And poor oral health impacts overall health and well-being, learning, and school attendance. And several studies have already shown the association between poor oral health and school readiness. So talking about the equity piece of why this conversation is so important, we need to look at the data. So half of Minnesota third graders have tooth decay, and 17% of them have untreated tooth decay, and 99% of tooth decay is preventable. Higher rates of tooth decay were more likely in rural communities and schools with higher concentration of students eligible for free and reduced price lunch, which means that there is disparities between income. So there was a survey that was conducted by National Association of School Nurses. The study found that some of the common issues in schools were toothache, cavity, or tooth decay, and general oral pain. But if the schools had children who were more eligible for free and reduced price lunch, meaning that children belonged to families from low income backgrounds, they also had jaw abscesses, facial swelling, and most of these children avoided smiling. So as we know that there are several barriers, especially social determinants of health, that affects access to healthcare, including the provision of providers, health literacy issues, financing, health behaviors. And in Minnesota, unfortunately, more than half of our counties already have shortage of dental providers. We also know that at least 13.2% of children are without dental insurance. However, just because a child or a family has dental insurance does not guarantee care, because there are several social determinants of health that impacts access to care. We also see the impact of the barriers that our children are facing. So less children under 6 hours.
Rashida, we can't hear you.
Oh yes, sorry.
Okay.
So less children are going to the dentist. That means less children are also getting, so only 38% of our children had a preventive dental visit. So there are proven oral disease prevention strategies, right? We already know what needs to be done. So for those of you who are not familiar with evidence-based interventions in oral health, fluoride varnish application is a very cost-effective intervention that can prevent or arrest the progression of tooth decay. We also have HPV vaccine, which has proven to be preventing a lot of oropharyngeal cancer. There is dental sealant, which is a coating that is placed in the molar teeth or the back teeth or the chewing surface of the back teeth so that it prevents decay, and it protects against 80% of the cavities for 2 years and 50% of cavities for up to 4 years. And through our SEAL Minnesota, which is our statewide coordinated in-school dental sealant programs, our grantees and partners have really been able to increase schools served by this program by 27%, and 39.2% of our children received a dental sealant through our partners. However, Minnesota Oral Health Program tracks high needs elementary schools for purpose of targeting school sealant programs. And we know for sure through this map here that over 200 schools, high-risk schools, do not have in-school dental sealant program. And in total, there are over 1,000 high-need elementary and middle public schools in Minnesota that need dental programs. So that is the reason why when we talk about medical dental integration, we see that school nurses could be champions of oral health because we cannot be in the school ourselves. So there are many opportunities for us to work with school nurses because there are school-based health centers, but we know that they are co-located with middle and high school. But if you are talking about fluoride varnish, sealant, and other immunization, you have to start early, right? So there are opportunities for us to expand the school-based health centers. There are also opportunities for us to get better aligned between health and education. And there are many, many other opportunities for us to bring communities and families into the scene, because they need to be part of the discussion as well. And we know that oral health integration is essential for overall well-being and academic performance of students. So school nurses can also play a major role in enhancing students' oral health, and data has shown that there are many children who are seeking help for oral health issues. They go to the school nurses. So school nurses have already been triaging these children. They are also helping us with community clinical linkages, and they continue to provide education both to the children and through them to the families. However, there are gaps in our system. So data shows that over half of the nurses are not well prepared by nursing programs or continuing education. Over 3/4 felt prepared to teach various topics, but they were not comfortable talking about how do we connect with a dental home. There are also gaps in different kinds of materials that school nurses need, such as piercing, orthodontic issues, access to providers, especially for youth from families with lower income, and 71% of wellness communities have no dental representative. So I would think that there are finite resources and infinite needs, and our school nurses have a lot on their plate already. So within that background, Jeremy has already talked about the whole school, whole community, whole child model. And this model, again, is student-centered, and there are many opportunities for both the families and children to get involved. And we are trying to reduce the chronic disease risk factors. So we are not looking at oral health just in terms of mouth. I think we are trying to put the mouth back in the body. That is the reason why oral health integration into the WSCC model becomes so important. So ASTDD, or our Association of State and Territorial Dental Directors, created oral health recommendation, and there are different domains that they have focused on. So for example, we know for sure that health education is an ongoing thing in the school. So can we talk about tooth decay and prevention of cavities in this particular class? Physical education is already part of the school curriculum. Can we talk about oral, facial, or injuries that can happen in the school as kids play? There are different kinds of health services going on. So can we bring in our Sealant program into this domain? Talking about nutrition services, can we talk about maybe adding a hydration station to schools so that there is better access to drinking water with fluoride, and it also substitutes sugar and sweetened beverages. So most of these strategies are so well laid out already. All we have to do is find champions within our medical arena. We found Jeremy, we were lucky enough, and he has really helped us be embedded into the WSCC model committees and efforts at the state level. So I would urge you to do the same in the communities that you serve. So there are also opportunities for our nurses, knowing that they are at their capacity. We can always advocate for them to be the oral health champions in the wellness committee. We can promote a lot of resources through the nurse's office. We can also talk to them about how can we expand school-based health centers. We can really have them link our school Sealant programs with the schools, and also ask them, or also work with them to promote oral health curriculum as part of the WSCC model. And the reason why WSCC model is transformative is it is a framework. It is not an intervention. And our school nurses or schools have the ability to pick and choose different components, because not all the schools have capacity to do the nutrition or physical education or everything that's kind of laid out for us for oral health. So they can pick and choose depending on what the needs are for the school. So as a state, we don't have to tell the school what they need to do, but it would be more like need-driven that the school nurse can decide. And it is also an equitable approach in improving access to health, education, and services. And finally, we can bring health and education together. This proposal was also submitted as part of our legislative proposal, and I'm very thankful to MDH leadership for helping us put this legislative proposal forward, along with our Child and Family Health Division within MDH. it was not funded is a different story, but at least we were able to come together as a state to put this proposal to advance the school-based program for our children. So there are different resources that we created recently to be able to support the WSC model. This is in-school dental sealant program, where we are really focusing on the role of school nurses. If you can see at the bottom, we've talked to your school nurse about Sealant, Minnesota, and the nurse, we see them talk to our community dental hygienist and through them to the dental homes. We also have created some bookmarks for children to talk so that the nurses can really give out. And this reminds me of another story I heard from a nurse at this conference recently. I would call her Nurse Jenny, and she said she has a club. So every time a child is losing their tooth, they run to her office and they get like little goodies, and along with that they also get the brushing demonstration, and they also get like a little like some oral health educational material. So I thought it would be a nice fit for us to be able to share these resources through these nurses' office, because we do have nurses who are already championing for oral health. So there are also opportunities for us to support schools and nurses through our hydration station grants. And this poster just talks about the importance of not just oral health, right, but how it is related to diabetes, and how drinking water with fluoride benefits the whole community as a whole. And we did talk about the vending machine also. So there are like multiple opportunities for us to use these kind of materials and put it into the bigger WSC model. So there are some work in progress. We've been working very closely with Denise Herman, who is the coordinator for school nurses at the agency level, and she's been a champion for oral health. And recently she let me and Dr. Kathy Phipps co-present to the school nurses, and we did receive a lot of good feedback. That was the first time we ever even worked with school nurses directly. We have been having conversations with our dental services advisory committee and dental societies and advisory boards about how can we work closely with school nurses. We also have some funding to bring on board a community dental hygienist who can actually connect school nurses with the dental programs or our school Sealant programs. That is a big ask from the schools. And we also would be bringing on board some community health workers to help with community clinical linkages part of it. So Nancy has been taking the lead on bringing all the Sealant partners together to see how we can share some data and be more informed about where these resources are, so we can be more geared towards serving high-risk schools. We are also planning to do some need assessment to understand what are the needs, because I think it's very important that we understand the needs and then offer our services rather than decide what we should be offering to our school nurses or the school for medical dental integration. And there would be some funding coming out of the CDC grant to be able to empower school nurses. So there might be some opportunities for us to do some pilots with them. I would really appreciate your help if you could reach out to me and let me know if you have any bright ideas as to how we can form these partnerships with school nurses. And this is our Minnesota Oral Health Statistics System. This is an interactive map that shows the green areas, especially the darker green areas, are dental professional shortage areas. And these dots represent schools served by our Sealant grantees. So there is also an example from Los Angeles County Department. So what they did was similar to Find Dentist websites we have in Minnesota. They have an interactive map where people can go in and find providers near the schools. But the idea is that these providers already have relationship with the county local public health agency, and they have committed to taking in the children for urgent care and then establishing a dental home for them. So I almost feel like we have a system already housed within our website where Minnesota Oral Health Statistics System, more commonly known as MINOS, can serve as that portal, but it would really need a lot of collaboration, and we would need to all come together to think about how this might play out within our context. And as we envision a dental home model for Minnesota. We see that, let's say this could be a child at the center. We want to make sure that dental home, community health centers, social workers, public health workers, community health workers, we all come together to establish a comprehensive dental home model. And when we talk about dental home model, this is not just the physical brick and mortar clinic. We are talking about the whole school, whole child, whole community model that could serve as an entry point into the dental system. Because when schools, clinical, and community sectors work synergistically, they can improve care and support patients better than either of these sectors could do alone to prevent, delay, or manage health conditions. So here are different resources that you can check out if you are willing to work more closely with the schools, or if you are already working closely with the schools. There are some very hands-on tips and resources that you can get from these websites. And at the end, I would really like to invite you all to join our efforts as we get kids ready for school, one school at a time, and maybe we can all come together to talk about actually implementing the WSCC model at the state level. So with that, I would ask Jeremy to provide his final comments, or Nancy at this time. Just looking at that time, do we take any questions? Or
We certainly have time for questions. Thank you both so much, and I'll let Jeremy.
Yeah, I would just add, to Prashita's presentation. I mean, right, the equity and any of that work, anti-racism, all of that is a foundational aspect of SHIP's goal and mission. And so, yeah, I mean, this really is, when we think about students, particularly those in the most need, that's what SHIP's role can be. And so it's a perfect fit, and it's a great partnership, and that's those successes that we want to see. So yeah, it really does align with our program as well.
And
Jeremy, I want to give a big shout out to Jeremy, and also acknowledge Bilkas Khan and Janelle. I get so emotional right now, but both of them have really put in a lot of effort to put up the data portal, and also Bilkas has done a lot of work directly with Jeremy, and so they moved on to different organizations for their career advancement, which we are very happy for them personally, not happy for the program though. So it's very important that, our small team has really put in a lot of efforts, but it's really Jeremy and more advocates like Jeremy who are championing oral health. And I would think they are behind the scenes all the time. So we just wanted to acknowledge Jeremy for making sure that oral health was part of the bigger model.
No problem.
Yeah,
We're
I
all
second
working on
that.
this together.
When Jeremy, during your presentation, when I saw the wellness policy and it included oral health, I was like, yes. Just integrating oral health into other wellness activities and other initiatives. And Prashita, I love the hydration stations. I don't know if I've told you this, but recently I was in the Boston airport with my water bottle, and I was walking all over the Boston airport, and I couldn't find one hydration station. And at our airport, they're everywhere. And I was like, oh, I need to talk to someone. So that is things like that. Integrating those pieces, right, into our world, they make a difference. And just real quickly, the Minnesota Oral Health Coalition, we have a YouTube channel, and we have a fluoride varnish training video. It's about 4 minutes. We have what we call a parent and guardian video in 8 languages. We're actually doing an additional 13 languages right now. So we'll let you know when those are available. And on our website, we have a tab called Meet Your Mouth. It's part of your body. And those are materials for your mouth and vaping. That made me think of that, Jeremy. Your mouth and sports, your mouth and aging. So we've got 1-pagers on those topics, and then we've got a separate folder filled with infographics for social media. So I just invite everyone to check those out. Thanks.
So Nancy, do we have a few more minutes to talk?
We do, yeah.
So I wanted to, because this has to be, I would want to get some guidance from the audience here. I think the big challenge we have is now we have the network and relationship, and through Denise Herman, we are able to get onto this base camp and then have everybody come together. And nurses are really advocating for oral health, but the issue is that they're not finding they're not finding any strategies to get connected to the dental homes or the programs. And as MDH Oral Health program, we won't be able to pick and choose different clinics to be referring the nurses, and we wouldn't even have that capacity. So there are conversations to bring on board a community dental hygienist who can do this, or maybe our staff who would be starting, I think probably January 17th, we have a new Sealant coordinator who might be able to contribute to this work. But I feel like this work has to be led by a community dental hygienist, because they understand the WSC model, they understand, not that others don't, but it's just a better fit in terms of the intervention that we offer to the school. So if you wanted to put this question out to the audience as to if they had any strategies about how can we work closely with school nurses, or is there anyone in the audience who's already doing that and maybe we can learn from them?
That's wonderful. And we do keep the chat. Jane and I will go through it too. So if somehow someone writes something and we don't capture it right now, we will have it. But yeah, if anyone wants something to share, Deb Jacoby's raising her hand.
Good morning, everyone. When you said that, Prashida, it is such an important thing. And I remember years ago working with Gail Kelly, and it was about Head Start, and she directed us to a website that had all of these great resources for families with children with special needs. And I was blown away. The people that were serving them could get training at that website. They could connect to a certified provider in their area, all of those things. And I was just blown away, and I asked how they got it, and they said some really effective advocacy. So there were parents who needed those services and they advocated for it. So I don't have the answer other than we have a rather large state budget surplus and one-time monies. And I wonder if there could be, and then it wouldn't be you picking and choosing, there would just be a hosted place, or maybe it's the coalition, I don't know. But a resource like that is what came into my mind when you posed the question, Dr. Prashida.
Thank you so much for that insight.
Can I say we have a question in the chat? Where can we access the resources you mentioned? Deb, do you know if that website is still around?
I don't know, but I will poke around and see if I can find it.
Okay.
It was a state website. Mm-hmm.
Oh, wonderful. And Holly Jorgensen has her hand up too. Thanks, Deb.
Hey, good morning. So Let's Smile, we work a lot with the school nurses. And you know what? I love working with school nurses, because when we first started with our school-based outreach dental clinics, and I started calling the school nurses, they are on board. They love this program. We were talking, the school nurses, they know all about how oral health affects overall health, because they see it every day in their students. And so as far as like, how do we get connected with the school nurses? I just really encourage any dental provider, any collaborative dental hygienist, anybody, just call the school nurse. And they are very excited about integrating a dental program with their schools. I gotta say, I mean, every school that I've called, they've just been very receptive, very on board. Except for one school, which I still struggle with, but I still offer them a proposal year after year after year. And I'm not really sure what's all going on with that one school. But for the majority, we're in 26 schools in Southeast Minnesota, and all of their school nurses and all of their social workers work really closely with us. So how do we do that? I just encourage making a phone call.
Thank you, Holly. I think there is still like work that needs to be done, right? Sort of.
Thank
So.
you. So it's time for us to go to our next speaker. Thank you both so much. And it just does my heart really, really good to meet you, Jeremy, and know that you're integrating oral health into SHIP, and that you're working with Prashida. I know that's really positive for us. So thank you.
And thank you everyone for having us here today. Thank you.
Definitely. Thank you.
Wonderful. And our next presenter is Nicole Farian. She is from Apple Tree Dental, and Nicole will let you share your screen. And I was remiss. I always want to thank our funder and our great supporter, Delta Dental and Minnesota Foundation. And I failed to mention them at the beginning of our event this morning, but we wouldn't be here without them. So thank you, and thanks for their guidance and their friendship as well. And I know they support a lot of us here, so thank you.
All right. Just get 1 second here. All right. Good morning. Can everyone hear me okay?
Yes. Good morning,
All right.
Nicole.
Thanks, Nancy. So thank you for taking time to listen to my presentation today. I will be discussing Apple Tree's medical dental integration activities at our center located in Fairmont, Minnesota. My name is Nicole Farian. I am a licensed dental hygienist with a master's degree in community health. I serve as Apple Tree's Clinical Innovations Director. On today's agenda, I will first give you an overview of Apple Tree Dental, and then discuss the medical dental integration project that I was fortunate enough to lead in Fairmont, and then address any questions you may have. Apple Tree is a nonprofit organization providing dental services to people regardless of insurance type. We have a passion for creating access to high quality dental care. Our mission is to overcome barriers to oral health, and our vision is to inspire partnerships that foster healthy communities. This is a map of our 8 centers. So when I say centers, it means locations. So each of the centers are one location in Minnesota, and the one that we're going to be talking about today is number 8 down in Fairmont. One of the facts that I like to call out on this slide is that in 2021, patients came from 85 of 87 Minnesota counties. And I call this out because we've already been talking about access to care issues this morning. And if you look at this map, yes, we do have 8 centers, and that is wonderful. But look at how far some of these counties are from our centers. We have patients that drive hours to see us. And I'll get into this a little bit further in future slides, but we do have pediatric specialists. We serve those individuals with disabilities, et cetera. So we do offer some specialty services. But what we hear all the time is that patients can't find a dentist to see them. And those of us that are familiar with the Medicaid dental environment in Minnesota know that access to care is an ongoing issue. And facts like this just really prove that. So we operate in 3 of our centers within a hospital or medical primary care. So we'll be discussing Fairmont today, but Little Falls and Medelia are also located within a hospital or a medical primary care center. I included a few slides to demonstrate the amount of care that we provide and Apple Tree's growth over the years. As you can see, we provided $35.7 million worth of services in 2021, and we predict we will be surpassing that in 2022. Here's just a few additional stats. We see patients of all ages. Like I mentioned, we provide care to the elderly, we provide care to young children. The majority, as you can see, are under 21 years of age. We do have providers that specialize in different skills, features, populations. So as I mentioned, we currently have 2 pediatric specialists that take complex pediatric cases. We have a lot of general dentists And then we also have some general dentists that offer different services. Like, for example, they serve individuals with disabilities or special needs that need to be seen in the OR. One of our providers has a passion for oral surgery, so provides a lot of oral surgery services. So that helps us meet the patient need. Apple Tree employs over 200 team members, both clinicians and support staff. The majority of our employees are clinicians. And as you can see here, we follow a practice model that uses providers of all types. Those of you that are familiar with the dental environment know that it's a very difficult time to try to find dental assistants and dental hygienists. So we operate under a model where we use licensed dental assistants, and the clinical assistants, those are unlicensed DAs that assist with the work under their scope of practice. We work with a lot of dentists, and as you can see here too, highly support a dental therapy model. We also have an extensive support staff team. They work on a variety of functions and positions ranging from lab work to marketing, leadership, operations, etc. So I mentioned this in the beginning, but we've created a staff model that has a team with special expertise. So we're really fortunate to have a staff that has expertise in these areas. So we do serve patients via IV sedation in the hospital. We do outpatient surgery at our Mounds View centers. We have a lot of our corporate staff with experience in fundraising and nonprofit development. Deb was just speaking earlier. She is one of our leaders in advocacy. So we are very lucky to have a diverse staff with lots of talents. Now, as we were just talking about with Prashita's presentation, it actually ties in really nicely. We believe in a community collaborative practice model. And so we often partner with schools, nursing homes, and various community stakeholders to best meet patient needs. And that's where medical dental integration also comes into play. So getting into the details of the medical dental integration project. So I started with Apple Tree in April of 2022, and I began working on the medical dental integration project at Fairmont. And that is a project that I'll be talking about here. The overall goal of the project was to improve care coordination for people with complex conditions, expand access to dental care in rural Minnesota, and improve oral and overall health. So as you probably saw on the map that I showed earlier of the Fairmont Center, it is located in greater Minnesota where access to care can be difficult. And so what we are trying to do is meet certain goals. And in addition to the overall goal, we selected several metrics to focus on. And so one of those was improving population health, reducing disparities, and reducing the impact of untreated oral diseases. Like Prashita was talking about, and I'll get into this further in the presentation as well, is in greater Minnesota, as well as the metro, but there's a lot of unmet oral needs. And so it's working to say, how can I work with a medical provider and a dental provider to focus on improving this? What can we do to make a change that is going to be beneficial? And that's where I'll talk about some of our school-based work, but that really ties in here. It's also important to build bidirectional medical dental care processes. So the Fairmont population, what we did is we identified conditions that are commonly experienced by the general population and seen by our medical partner there, our medical clinic partner, and then also us. So some of these specific conditions include diabetes, heart disease, stroke, and pregnancy. So throughout the period of this project, those were our main focuses. In order to successfully refer back and forth and also help meet the needs of patients, both from a dental team and medical team perspective, there's a need for training. and like interprofessional training, and then also a creation of educational and referral resources. And I'll show you some of the examples as we get further on. And then lastly, we all know that urgent care and emergency room visits for dental pain are a problem. They're very costly, and they're also very difficult for patients because, you know, they go to the emergency room and their need isn't able to be met. And so one of the very important tasks for this project was to try to work together. The medical clinic partner is also in Fairmont. And so we're co-located. And so it works really great in terms of a partnership perspective. At our other centers that I mentioned are co-located as well, to be able to refer back and forth to each other. So the 4 main focuses of the project were mobile dentistry, building a medical dental integration team, interprofessional education, and then also establishing that referral system. How can we reduce the amount of patients that are being seen in the emergency room for dental pain and also urgent care? And when they do show up, what can we do about them so that we can offer them a better patient experience? So the first mobile activity we engaged in was a custom athletic mouth guard event. So we had various work sessions with our medical clinic partner, and we learned through one of our conversations that they offer sports physicals. So down in the Fairmont area, so it's Fairmont and then surrounding areas, they have a mobile unit, and they choose various locations, usually high schools, to go to throughout the summer and offer these sports physical events because they are required for participation in the athletic programs at school. And so, Nancy, you were talking about Meet Your Mouth earlier. It was funny because I had just looked at the Meet Your Mouth in sports, and it had talked about the importance of athletic mouth guards. And so one of the conversations was these kids need sports physicals, but they also need athletic mouth guards. And I think we all know how uncomfortable and ill-fitting at times boil and bite mouth guards can be. And so obviously custom athletic mouth guards are ideal, but they're usually very expensive and hard to access. I think most parents with children are very busy and don't have time to bring them to a dentist to have a custom athletic mouth guard made, nor do they even think about it from a cost perspective and time. It's just laborious. So what we decided to do is to pair with the medical clinic partner. They were going to be at this location in Fairmont anyway. So it was at the Fairmont Junior Senior High School. And there were 2 days of the event. As you can see, the flyer from the event is on the right. And so we created the flyer and we sent it out to the community via our social media page. And we also asked our medical clinic partner to share it as well. And then we also were asked from community members from our staff that lived there to send it in to publish it in a newspaper. And that actually worked really well. I'm not sure, like in the metro, if it would work quite as well. I think maybe because Fairmont is a smaller area, there's a popular newspaper that people review, and that had a really big impact. So it was a great event. So the mobile unit was parked, and the medical clinic partner was rendering sports physicals. And then the patients were able to come over and get a custom athletic mouth guard at the same time. So it was like a 2-for-1. They were covered. And we did some research before the event and identified what schools we thought would be coming, like kids from which schools. And then we picked a few colors that they'd be able to choose from, because of course that's very important to kids that they have a cool looking mouth guard. And I'm laughing because at the time, a lot of the students chose white, and I did not know that was like, I'm flabbergasted by this, thinking, why would they choose white? I would think that they would choose a fun color, but my son now entered 6th grade, and apparently white is very cool. White is like the color. So now I'm not so surprised. White is popular. So I guess when they smile, because a lot of coaches will make them, smile, they can see just very, very bright white mouth guards. So that was a really cool way to be able to be out in the community meet community members, engage with the medical clinic partner, and to be able to offer a service like this. I know I personally would love to wear a custom mouth guard rather than a boiled bite. Another item that we have been working on in terms of mobile dentistry is school-based care. And it was almost like this was planned to have Prashida go first because this presentation really ties in. So we have partnered with a local elementary school to deliver school-based care. And we started this just last week. So 38 children were seen over a 2-day span, and then preventative and diagnostic services were provided. So there was dental assistants, a dental hygienist, a dental therapist, and then also a dentist that were involved within a 2-day period. And so the children at the school that were seen, they aged in range from 6 to 11 years of age. And this was a shocking fact to me, but again, speaks to what Prashida was talking about. So 6 to 11 years old, 70% of them, it was their very first dental visit. So, and then furthermore, of the 70% that were seen, 80% have unmet treatment needs. And then half of that 80%, they have very extensive treatment plans. So it just really ties into the need of school-based care. I mean, to meet these kids where they're at, because if they're 6 to 11 years, I mean, we strive to even have, a 1-year checkup. I know for a while, some parents weren't taking their children until they're 3, but these kids are 6 to 11 years old. And for 70% of them to not have seen a dentist at some point in their life, that's pretty tough. And think about if there's 70% of them that have this first dental visit and 80% have unmet needs. Think about the dental disease and the pain that they're dealing with in school. So I feel really lucky that we were able to provide this care. And then in terms of next steps, Dr. Jesse Grants, he is one of the dentists at Fairmont. He provided exams for the children and determined which children could be treated at the school versus which children would need to be treated at Apple Tree under the use of nitrous oxide. So there were a few of them, not a large majority, that he felt would do better with nitrous oxide. So we'll be providing school-based care. So those of you that aren't familiar with how our mobile dentistry works, we do not operate in like a mobile van. We have mobile equipment that we have a truck that moves the mobile equipment to the site. So then we set it up in a space, and it's just like having a dental office in this space. So treatment will be provided after we have consent forms signed for the patients. It's a very high Hispanic population in this area. And so we have multilingual care coordinators working with parents to get treatment plans signed. And once so, we'll move forward with treatment. And I'm sure all of you know about the viruses going around right now. So there were some children that were out ill and unable to be seen, but we will catch them at our next visits to the school. Another mobile effort that we've engaged in is nursing home care. So Apple Tree has relationships with nursing homes throughout the state, but in Fairmont, we have just started partnering with a local nursing home to provide care to the residents in their facility. And so the program is being built, but the first step is to do assessments of each resident to see what their needs are. And next week, one of Apple Tree's dental therapists, who serves as the center director for our office in Fairmont, will be going out to start those assessments. And then once complete, we will be rendering comprehensive care at the site, again, using our mobile dental office equipment. Another project focus was establishing a medical dental integration team. So when we worked with a medical clinic partner and identified who from Apple Tree and who from our partner should be included in these conversations. And so the employees range from all levels of the organization, leadership, clinical, and project management roles. And we met on a regular basis. So we, as you saw from a few slides ago, we established what our goals were. We established what metrics we wanted to make. And so I held weekly internal meetings with our staff so that we could have collaborative work sessions, ensure that our goals were being met in a timely fashion, et cetera. And we also scheduled regular touch points with our medical clinic partner team to again ensure that we're having collaborative conversation, discuss new ideas, talk about what was working, what isn't, and then to schedule upcoming events. As you can see here, interprofessional education and practice was also an important piece. So Dr. Jesse Grants is in the image on the right. He is a dentist at our Fairmont Center, and he is presenting here to the primary care doctors at our medical clinic partners office. And there were two presentations like this. The first one focused on introduction to dental exams. And then the second one was oral impacts of diabetes, hypertension, and pregnancy. And through our work sessions with our medical clinic partner, those were the conditions that were chosen because those are the ones that are most experienced by the community. And I'll get into a little bit more detail in terms of the content. So for the exams, Dr. Grants presented to the doctors just about it was like a dental exam 101. Like what does the doctor do during the dental exams? And then also had a collaborative conversation with them in regards to what they should be looking for when they're doing well child exams. Because what if they're seeing a patient one of the patients that hasn't been to the dentist yet? We would like to work with the medical partner to have the doctors at least be able to identify what's SDF versus decay. What are the major points that we need to say, oh, okay, like this needs to go to a dental referral. So, and these were presentations in nature, but it was also very collaborative. So Dr. Grants would ask the medical providers questions like, what do you see on a day-to-day basis? How do you handle X, etc., which helps him gain knowledge and bring that back to our staff. And then he would provide them with dental information so that they were up to speed. As I mentioned, you can see in the second bullet here, one of the things that he focused on was how could they detect caries just visually, what is a standard fluoride frequency, and worked with them to ensure that they were successfully implementing fluoride varnishes in their medical practice. And then also SDF education and training as well. For those that aren't well versed in SDF, obviously it can look like decay if it's a dark stained tooth. But silver diamine fluoride is something that Appletree utilizes, and so wanted to get the medical providers up to speed as to why it's used, why it looks that way, etc. And then in terms of the oral impacts of chronic conditions, there was a lot of collaborative discussion about certain medications, side effects to those, and then the importance of a dental home for pregnant patients. So I think in an earlier presentation and also discussions with the Minnesota Oral Health Coalition, we've talked about the importance of patients who are pregnant receiving care. And so what we found is that our medical clinic partners, medical providers weren't always talking to pregnant women about the importance of dental care. And then also having those conversations with their newborns, right? What should they be doing? When should they see a dentist? So I think building upon education is really important because there were a lot of what we as dental professionals would call basic tips in terms of taking care of teeth, taking care of patients that the medical providers weren't educated on. Even diabetes and the link between diabetes and periodontal disease and how those conditions can be worsened by each other. So it was a very informative process, and relationships were able to be built between our dental providers and their medical providers. Another thing that we focus on is how can we make a better referral system? So, sorry about that. It's a two-way street here where, again, we're co-located with our medical clinic partner. So that makes it much easier in terms of working together and for the patient experience. But currently, if Appletree has a patient that, well, we'll start with me or with our medical clinic partner first. So if there's a patient in the emergency room or urgent care and they have tooth pain, they can just be walked over to Appletree by a nurse. So that is a really cool thing because it's not just, hey, patient, like you have a dental need, we'll give you an antibiotic, but now you need to go find someone. And as we had discussed earlier in Prashida's presentation too, there's a problem with finding a dental home. So if a patient's in the ER or they're in urgent care, if you just tell them, well, you need to go to the dentist, it's like, well, who do I call? How do I find a dentist that actually will accept my insurance? There's a lot of barriers there. So we're really proud to be able to offer this service, in that it's so personal, in that we don't just, Mayo doesn't, or a medical clinic partner doesn't just have to tell them, hey, you need to go ahead and call some number, like call the back of your insurance card. They can walk them over to us. And what we also did is we created a handout for their medical clinic partner to give to patients. So instead of just saying, because there are some patients that don't want to walk over to our clinic, say they're in pain, they have other family commitments to make it to, they just want to get out of there. And so we created a handout, and the handout has our contact information of it, a picture of our doctors, phone numbers, it has where we are located in the building. So the medical staff can just give it to the patient, and the patient can walk over, call us, etc., in order to schedule an appointment to address their needs. And then it goes the other way too. We often have patients that we need a medical referral for. So oftentimes we'll start treatment, or we'll want to start treatment, and we'll find that the patient has hypertension or uncontrolled diabetes or some other condition where we can't safely perform treatment. And so in that scenario, we worked with a medical clinic partner to say, what do you need from us? How can we best assist in this situation? And so what we did is we decided, we looked through various electronic health record documents to see like how much information should we send with a patient. And they found that the referral form that we built is perfect because it has enough information to give the doctor a reason of why the patient is there that day, and who they can contact if they have questions, instead of the patient just walking over saying, I'm Nicole Farian, I was at the dentist and they said that I had high blood pressure, so I need to see you first. Instead, they bring over the referral form, and it talks about what date I was seen, what my blood pressure reading was at, what the dentist wants to do, and what the purpose of the referral. And then also our dentist contact information if they have questions. So that's been really beneficial too. We tried to just make the process easier for both parties, from an administration standpoint, and then also the best experience for the patient too. All right, so that ends the overview of our medical dental integration project. Are there any questions? I'll stop sharing here.
Thank you so much, Nicole.
You're welcome.
This is so interesting. I love what you guys are doing. And I put into the chat that your Fairmont clinic hosted our early childhood dental network meeting. So Jane Neubauer and I were able to be there and see the clinic. And it's just amazing because we're in this Mayo Clinic building and we're in a dental clinic. So yeah, so if anyone has any comments or questions, you can unmute yourself. You could put something in the chat. Nicole, we'll share your contact information, right?
Perfect. Yeah, otherwise I can put it in the chat too, whatever.
That'd be great.
Just put it in the chat right now.
Thank you.
Sure.
Yeah, that would be wonderful.
Okay.
You know, I was really struck by the professional education and how important I know that is. We all do. So to see that that you're doing education, diabetes, hypertension, pregnancy with primary docs, and that's really outstanding. And also that referral system, because we know that could really be a hang up for our medical dental integration. So awesome. Yeah. And that handout too, I was making notes. I was like, oh. And then lastly, the other thing that really struck me was obviously the 6 to 11-year-olds. When you said 70% of them, it was their first visit. And all I could think of is, what if you weren't there?
Exactly.
Right? When would their first visit be?
Well, I'm
So,
talking about how like the school nurses are advocates for having dentists come in. It's because that's exactly right. They see it. They see that it's hard for the children to learn when they're in pain and the struggles that they go through. I think sometimes if people don't actually experience things, especially when you're not in the dental profession, you don't think about that. It's like, oh, well, I have a cavity. My dentist said I need to fill it. But there's these children that have serious dental pain, infection, etc. And I just feel really lucky that we're at least able to go into those schools and render care, because that's really truly making a difference.
absolutely. And Dr. Helgeson, welcome. And
yeah, thank you. I just, of course, I'm biased, but I wanted to thank Nicole for that presentation. But I did want to comment that a lot of the work preceding this, happening at Medelia initially over a couple of decades, and then up at St. Gabriel's, where we did a project related to opioid reduction there, which was a system-wide collaboration between lots of community partners up in the Little Falls area. So yeah, it's fun to see this happening, and the fact that we were able to pull off opening that clinic with Mayo in 2020, right in the middle of the pandemic.
yeah,
And that we've been able to get this kind of work going, even under the stresses that everyone in healthcare are under right now, with all of these different burdens, not the least of which is COVID still happening, and the going around and so on. But anyway, I think it's an exciting area, and we're looking forward to more progress as that program just gets started, and really the birth of the mobile program out of Fairmont happening right now too is kind of an exciting time period. So anyway, I'll sign off, but thank you.
Yeah, no, thank you for that, Dr. Helgeson, because you made so many good points, but one of them that I love is we see this finished product, or we see this clinic, with this integration, and to think that a lot went into this. And it's funny, that was the first meeting I went to live in person, was that to go to Fairmont. So thank you so much.
All right. Well, have a great day, everyone.
Yeah, thank you. We appreciate it. And last but definitely not least, I want to welcome Sarah Wovcha. Oh, I'm sorry, Sharon Oswald.
Sorry, I don't know what I'm doing with my hand here. I was trying to raise it, but it was late, and then I was trying to unraise it. But if we do have a second, I did just want to, and this might be for Dr. Helgeson and Nicole both. And maybe there's somebody here from Mayo on the call, but I'm just curious. This is, fabulous headway and really exciting work. And I'm curious, like from a systems perspective, what you're seeing with the Mayo leadership, if there's any kind of interest in growing this, like, or, where's the opportunity from here? I guess when you look at that partnership.
Yeah, I think it's very exciting. I think a lot of people know that our Rochester Center was actually created with leadership from Mayo Clinic geriatricians, and with lead support from the Mayo Clinic's Foundation and so forth. So we've had a relationship with the Mayo Clinic that's extended for quite a period of time. And then many people know Dr. Aaron Westfall in Mankato and the work that's being done there, which we've been collaborating with our Medelia Clinic on that project. And then we are part of the Mayo Clinic's Rochester Epidemiology Project, which is really the world's leading epidemiology project. They have lifelong medical records from really all the providers for 95% of all the people that live in Olmsted County, which that kind of data really doesn't exist anywhere else on the planet. So we are their partner in research for linking oral health records to that medical records system. And the last 3 or 4 years, we've been onboarding all of our patients in the geography that maps down there with Mayo Clinic. So I'm probably most excited, to be honest with you, about that, being able to actually do longitudinal studies of the impact of oral health for people of all ages with the Mayo Clinic down there. So I'm excited about it, and we're looking at ways to electronically exchange data. And the state of Minnesota had a health information exchange project pre-pandemic to create some linkages between the main health information exchanges in the state. And that hasn't moved forward during the pandemic for a while. But we're hoping the state will get that linkage in place, and that would allow all the different kinds of providers with different electronic health record systems to be able to exchange information electronically, rather than having to do little workarounds and things along those lines. So that's been a topic for us, especially with our long-term care partners, where their electronic records are so enormous as they grow this data, and dealing with the old-fashioned systems for that much information is really it's a burden on everybody. So anyway, thank you for the question. It's a great question.
Thank you so much.
Yeah, thank you, Sharon. It's good to see you. All right. Our next presenter is Sarah Wolfcha. And Sarah, if you want to share your screen, Sarah is going to talk about dental and medical integration partnerships, pediatric, WIC, and Head Start settings. So great, great topic for today, for this morning.
Yeah, thanks, Nancy. And you know what? I am going to ask you all to talk and take a little time because my it shut down. So I'm sorry, I'm having a little technical issue. So can you all talk for a minute?
You could do that. Talk amongst yourselves.
Yeah. Technology. This is what my IT husband says. Technology is great until it isn't.
Right.
And the rules of rock and roll, turn it on, turn it off, turn it off. Unfortunately, my program decided to turn itself off here. So I am really.
Sarah, if you want me to run your presentation, I can do that.
You know what? Maybe that would be faster, Nancy. If you are so
I'm happy
willing,
to. I'll
you
share
would be
my screen,
fine.
and then I'll watch you, and you can give me a hand signal, or you can tell me to.
Nice. Okay.
that?
Thank you for working with me.
Partnerships, right?
Yeah. This is a cross. I don't know what this is. This is the technology partnership.
There we go.
Okay. Thank you so much. And I will have it actually going on my other computer. So I just want to say, Nancy, thank you for doing this. All of our lovely funders who make this presentation possible and our work, as Nancy said, Delta Dental of Minnesota, Blue Cross Blue Shield Foundation, Medica UK. I mean, I'm sure I'm going to miss somebody, but we couldn't do this without the incredible philanthropy that we have. I am here to talk about what we at Children's Dental Services do around medical dental integration. And I am the executive director. I've been here and I'm in my 22nd year. So a little bit about who we are. Children's Dental Services was established in 1919 by a group of charitable women in Minneapolis in the wake of the Spanish flu pandemic. So I feel like we have just come full circle. The purpose of our original Southdown Children's Clinic, it was called at the time, was to care for the needs of orphaned children in the wake of that pandemic. And we, interestingly, at that time, we were established as a medical and dental integrated clinic. Our kiddos received both medical and dental care at that time. And they were ahead of the time. They knew what they were doing. We have been in the portable care space since the 1960s. We were for a significant period of time co-located with the City of Minneapolis Women's and Children's Oral Health Program, and through that program delivered care in vans to schools all across Minneapolis, which again was integrating with the school health clinics. And in the late 1960s, we became the first dental program in the nation to bring dental services on site in Head Starts. And we did that with PICA Head Start. My predecessor established that relationship. It was really novel for the time. So today we have 2 bricks and mortar clinics in Northeast Minneapolis and 1 under construction to be opened in the early 2023 in Duluth. But on any given day, more than 2/3 of our providers and services are delivered all over the state of Minnesota. In any given year, we have between 500 and 700 portable locations where we go to deliver services. And those are mainly integrated care sites that I'm going to talk about today. Next slide. So just a little bit about me. I think of myself as a little bit of like a social service dental integration person. I'm not a dentist or a dental hygienist. So my board 22 years ago thought outside the box a little, and actually we're looking for somebody who had some different skill sets. I was a social worker for 4 years and then a lawyer. And the kind of law that I focused on though was legal aid, so services for low-income people. I worked on a Violence Against Women's Act project, and I was a staff attorney at the Eastside American Indian Center in St. Paul, and also Young Native American Children's Shelter. So my specialty was ICWA and care for, or Indian Child Welfare Act, and care for disadvantaged kids and families. And that all, this is what I think is so fascinating about oral health. It's all relevant. It all comes together. It's all part of the health of the whole child and the whole family. What is this photo? This is the funnest day in my entire life. I'm doing outreach in a school-based clinic, Piedmont Elementary in Duluth, on a day when the tooth fairy got sick. So I had to pull out my daughter's tutu and tiara and be the tooth fairy. So fun. I totally recommend it. Next slide. So these are counties where Children's Dental Services either, has provided some level of care, whether it's an outreach clinic, whether it's a portable clinic. In fact, the vast majority, of course, are portable clinics. So this is where we were in 2021. We have a really strong presence in northern and northeast Minnesota. And we actually have our services co-located with other bricks and mortar facilities there. For example, we have an office dedicated at United Way of Northeast Minnesota and Chisholm, Minnesota, and other locations like that. And so in 2021, we had over 64,000 patient visits in Minnesota. Next slide. Here are our demographics. So we really focus on those without. We often, when we go into a community, we say, or if we're asked to come into a community, we say, if folks already have a dentist, we're not here for them. We're here to eliminate gaps in access to care. And that largely means, over 97% of who we serve are low income based on the federal poverty guidelines. The vast majority, currently we have about 86% of folks on on medical assistance. And we have some on commercial insurance, although I'll say that with our commercial insurance numbers, sometimes those deductibles are so high that we process them on sliding scale. We're seeing some deductibles of $4,000 or $5,000, so that doesn't really feel like being insured. And we serve uninsured folks on our sliding scale, and over 80% of them receive free care. Our patient demographics are highly diverse. The pie chart on the left shows the just incredible, sort of rainbow of different cultures and ethnicities that we serve at Children's Dental Services. And we really, as an organization, work to represent the communities we serve. So more than half of our staff represent those communities. We have from 26 countries, and we speak just as many languages. Next slide, please. So I want to talk about just oral health in context. So, and I think that we as have managed somehow to segregate the mouth from the body in a way that doesn't do us any favors. And what I love about medical dental integration is that it feels like it's reintegrating those systems. So when we're thinking about our hub-based care, we are thinking about how can we couple what we're delivering with the other supports and the other professionals who are going to support that child, and the things that impact them, their interpersonal factors, so social supports, their institutional factors. So, can we be considering going to a location where they're going to get multiple services from various institutional providers? We think about the community factors, the physical environment. How easy is it to get there? How, is it on a bus line? Are there other things nearby that family is going to be traveling to? And then we think about policy factors, like how can we be ensuring that folks actually have the health insurance or the sliding scale or what have you in order to be able to actually attain services in a location. Next slide. And we think of the determinants of health. So when we integrate oral health with medical services and other social services, we're really beginning to think about the broader picture of determinants of health and how we can navigate those. So how can we together be considering, and this is sort of paraphrasing what I said in my previous slide, culture and society, educational systems, health systems, how can we be pulling those all together into one, and that makes it accessible, that makes it make sense from a policy perspective, that makes it cost effective, and that in the end provides quality outcomes. Next slide. Okay. So with that in mind, we've seen a lot of different examples today about what is medical and dental integration, and just sort of like the high level definition that we have. It's the practice of both medical and dental providers working collaboratively to improve overall patient health. And in the examples that I'm going to provide, it's not just nurses and doctors, but we're also we loop in mental health providers, substance misuse providers, et cetera, in that equation, early education as well. All right, next slide. Why is Minnesota ripe for this? I think that this was covered well, in Nicole Farian and her slides was just showing the breadth. We're a fairly big state geographically, and more than 50% of our counties are dental professional shortage areas, designated as not having adequate access to care. So right there, we get a sense of there's a problem. We need to be thinking of innovative ways to addressing them. Dental disease is the #1 cause of absences for children in school. And so co-locating dental care and medical care in a school health clinic, for example, reduces the number of visits a family needs to schedule and reduces the amount of time that students miss school to receive care. And then, of course, eliminates the pain that distracts from learning. And anyone with a toothache knows there's just no way you're going to learn when you're dealing with that. All right, next. Oh, Nancy, could you advance the slide?
Oh,
yeah. Okay. So we call our model a medical and dental hub, where we're going to a single hub location that includes multiple different services of various types. And we believe that this model is a best practice. HRSA, CMS, our own Department of Health recommend this model as an effective, cost-effective and efficient way to provide services. As discussed before, it's collaborative in that there are interdisciplinary partnerships. The efficiency is that miles can become steps when people are already going to a location, and then they can access other services right there in the same building. That is a huge removal of a barrier for low-income and vulnerable families. We all note that we work really carefully to make sure that these hubs are in convenient, centrally located geographic regions, and or that they are where communities are naturally congregating anyway. Maybe it's at their church, maybe it's at their child's school, as I mentioned, and that together, when we can get all of these things under one roof in a hub, we're going to decrease barriers, expand access, reduce health disparities, and improve health outcomes. Next slide, please. Okay. And here's just another image that I really appreciate about the benefits of dental and other health disciplines being integrated. This one I found from the Dimensions of Dental Hygiene publication, showing that true integration is bi-directional and collaborative. And I love seeing here that dental, this image showing dental as being integrated with medical, behavioral health, pharmacy, and other social support services. Next slide. So now kind of diving into the specific types of integration partnerships that we have at Children's Dental Services, because there's really an array. We go to pediatric clinics, family medicine practices, family nurse practitioner practices, I mentioned school health centers, women, infants, and children, or WIC clinics, Head Starts. We go to mental health centers, residential treatment facilities, and these are just a few. And I think what is lovely about this, that any of us thinking about doing this kind of work can really consider where are those places in our communities where families, children, vulnerable folks are naturally congregating, and how can we think about turning those into integrative dental provider settings. Next. All right, so, and now I'm just going to show you some images of our folks in action. So this is our Brooklyn Center Medical Clinic, and here we have an advanced dental therapist providing providing dental services right on site. And this clinic also happens to be adjacent to a school and a transit center for the community. Next. I mentioned women, infants, and children partnerships. So we are now co-located with more than 30 WIC clinics across Minnesota. And in those locations, we are, when patients come to receive their dental care, they're also able to receive nutrition services, immunizations, visits with public health nurses. And we have an opportunity also to kind of link in with the programming and say, if this is a day when people are most likely to be coming to pick up boxes of food, let's consider scheduling on that same date. So folks are already coming. So that's integrating within an integrated system. How are we collaborating and working together to make the visits and the timing of the visits as impactful and efficient for families as possible? Next slide. So here we are at a WIC, St. Louis County WIC clinic in Virginia, Minnesota. Next. So school-based health centers, I mentioned those before, and school-based health centers are their own thing. They've been a part of our national and our state systems of delivering health to youth for decades. And so what are the things that happen together in those school health settings? Chronic disease management, acute and emergency care. Whenever you have a kid injured on the playground, we've had plenty of times when kiddos are, they broke a tooth during recess or whatever, they go to that school health office to address it. Care coordination. So whatever services are not being provided at that school, there's a lot of referral and coordination going on to make sure that they occur. And then family engagement. It's an accessible location for families to interface with the school about healthcare needs. I'll give an example. At the health clinics that we go to, we have some regular patients who we time our visit to them when they're coming in and getting other services. They're literally being treated for their asthma, their behavioral conditions, or many other things at that nurse's office the same time when we're coming in and doing our services. Next slide. And here we are in Duluth Public Schools. This is one of our Northeast Minnesota hygienists with kiddos up there. Next slide. Head Start partnerships. As I mentioned, that's a really longstanding partnership and model of care that we have. We're currently in over 20 Head Start centers across Minnesota. And in those settings, we're really finding our synchronicity with the Head Start holistic care model. Head Start is looking, there's a very robust even system for getting families enrolled in a Head Start that involves a medical visit, immunizations, a dental screening, looking at behavioral health needs, looking at the needs of pregnant moms, establishing home health routines, et cetera. It's just an incredibly ripe environment for addressing the whole needs of the whole child, in addition to early education. And they just do such an amazing job, even integrating, toothbrushing into the regular activities that they're doing in the classroom. And we get to be part of that, which is really exciting. Next slide. So here we are. We go to, as I mentioned, Head Starts all over, lots in the metro area, but we're also quite far afield in Minnesota. So here we are in Crookston, Minnesota. Next slide. So I want to just share some nuts and bolts considerations before I pause for question and answer. So it's a fabulous model. And what are some of the things we think about when we do it? Anytime we collaborate, there's going to be an added level of complexity, right? You're not just going it alone, you're working with other folks. So we always have a memo of understanding or a contract between our organization and the host organization. And just some ideas of things to consider that in the beginning we didn't consider as much. What's going to happen in the reception area? Are we going to share it? Are there going to be expectations of where their patients go or our patients go? Is it big enough for everybody? And that's an especially, it's been an especially interesting thing to navigate in a time of COVID. We had expectations, we would be at, a WIC clinic in Carlton County, and folks weren't allowed to be in the waiting room. They needed to be out in cars. How are we going to deal with that in a rural community in sub-zero weather? Lots of interesting things to think about, but good to think of them upfront. What is the internet capability when you're doing portable services? We're doing telehealth with them as well. And all of our records in our open dental system need to have internet connection. So is there a firewall? Will we be allowed to use it? Do we need to bring hotspots? What are the expectations for waste disposal? If we're going to have a hazardous waste, how are we going to handle that? That's ultimately our responsibility. And who's liable? So we have, pretty developed protocol for addressing liability between the sites. Another thing to consider, who's scheduling? Sometimes sites they're already scheduling things, so they want to schedule our patients as well. or they want nothing to do with that. It's a whole other can of worms. So they're like, you handle that, but integrate it with our stuff. That's something really important to consider. And if the partner wants to schedule for you, do they know everything that they need? Do they have all the tools in their toolbox to do that? Because we have complex patients, we have an obligation to make sure that as we schedule, we're aware and being really mindful of scheduling in a way that meets their needs. Other considerations, although I think it's highly efficient and that is highly efficient, replicable, and that there are, you know, opportunities for cost savings, it can be really expensive, especially, you know, our model, we are literally delivering portable equipment into other locations. There's a time involved in transporting from site A to B. Sometimes the providers are taking that equipment with them. Most of the time we're delivering it. Our delivery team is delivering it. So how are we going to meet the funding needs? And we also do a cost benefit analysis. There are counties in Minnesota, at least 2, who don't have a single dentist residing within them. So there's going to be a high need for bringing the care in at a greater expense than if they just had a clinic like right around the block. But maybe they don't have enough need, or maybe there just aren't the resources to be able to support that local bricks and mortar clinic. So how much are we going to spend to bring the care in? It's something to think about. It's something to plan for. I think that's a really, really important piece to be cognizant of from the get-go. Next slide, please. That is my sort of high view of how we at Children's Dental Services look at integrating across the medical health spectrum. And I'm really inspired also, I want to say, by looking at others' models of doing this. There's certainly, you know, you've seen one integrated care model, you've seen one integrated care model, in my opinion, like just as many lakes in Minnesota, right?
Yeah.
So with that, I would love to open it up for questions. And if now's not a good time, I love talking with people. So feel free to reach me anytime that's good for you.
Well, thank you so much, Sarah. I love hearing about Children's Dental Services. It is amazing when you think about 500 to 700 sites where you've got mobile clinics and mobile setups. I always appreciate when you present on what Children's Dental Services is doing. You always give us the nuts and bolts. I mean, I was making notes and I thought, oh, just the most simple things like waste management, like garbage. And again, that idea of who's going to schedule, and if they schedule for you, do they know what to ask? Do they know what you need? So, and really important that you guys are there on the day where you're most likely to see the greatest number of people. They're already going to be there for something else. So that's wonderful. Any questions? I know, let's see. Anybody have any questions, comments, anything that you want to share or questions of Sarah? I think we've been really, really lucky today. Our presentations really worked well with each other. I'd like to say I had a master plan. I did not. But yeah, anything that anyone would like to share? If not, we'll be sharing Sarah's materials, and they do include her contact info, or if you miss them somehow, get a hold of me. I can connect you with Sarah. So thanks to
Nancy. Oh, sorry.
Yeah.
I saw a question from Clifford Lisman.
Oh, okay. I
Yes.
didn't see it.
Have you considered adding combination for medical dental nutrition? Obviously, what affects the mouth affects the body, and that could be a significant improvement in outcomes overall and cost savings.
Thank you so much for bringing that up. And I didn't dive into exactly what our providers are doing at each of those visits but so I'll share that now. And it varies from site to site. We target it depending on which site that we're going to. So I love this question because it's a great reminder. So when we do couple visits with nutrition education, and I'm just going to say that is such an important, I mean, WIC, it's coupled with nutrition, but it's a really important topic at all of the locations that we go to, schools, Head Starts. I neglected to say that we also co-locate with a number of service organizations targeting various diverse populations, immigrants and refugees. Right at this moment, we're doing a lot of care to refugees from Ukraine and Afghanistan. And so what I love about the question that Clifford Listman made is that we talk about what was the nutrition in the country from which the immigrant departed, and what is it here? So if they had a primarily rice-based diet, for example, usually in the host country, even in refugee camps, the rice tends to be higher grain, more nutritious, less processed. And you even hear about this healthy immigrant effect. They come in and they might have some actually healthier habits, and then they come and they start to eat processed food, and they all of a sudden are having diabetes and poor oral health, etc. What other nutrition things are we talking about? As a mom of 3 teenagers, I am sad to say that lots of high schools have vending machines, and they're not full of good stuff. They're full of sodas and candies and things like that. So we're talking about that with kids, where we talk about rethink your drink. Another thing about our immigrant and refugee population is that they may have come from a place that did not have a reliable water source. And so they believe when they're trained to think, I need to have bottled water or Coca-Cola. And so we show and talk about how much sugar is in each of those, and what we can offer here. Minnesota, most places in Minnesota have among the healthiest fluoridated water supply in the nation, and families can save a lot of their household dollars if they drink that water. It's going to be better for their mouths. They're not going to be bathed in sugar. They're not going to be creating a lot of plastic bottles. There's just so many win-wins around that. So that's really important. What else are we doing? In our schools, we're talking about vaping and smokeless tobacco, and what is that doing to their teeth? And I tell you, if you thought that your kids didn't do that, kind of everybody vapes now. It is such an epidemic, and it leads to other things. And we're seeing it, we see it in low-income schools, we see it in higher income schools. I just think it's interesting how pervasive it is, and the marketing going after our teens and using those products. So every time we go to our site, we are targeting oral health education to the specific needs of that population, and then also providing them tooth kits with the things they need. So like if we're in a WIC center, we're giving them baby mouth wipes, et cetera, along with their toothbrushes and paste and timers, et cetera. So it's a great question. I think we could talk for hours more about oral health, nutrition, the various diverse communities and approaches that we use within them. Thank you.
I love that question, because now I just have about 30 other things that came to mind just from your reply, Sarah, just foods. And it's certainly something for another meeting that we have, another gathering we have, is to talk about nutrition. Thank you for that. It's almost 11, and I promised I'd have you out by 11. Thank you again to Sarah and our other presenters today, Jeremy and Nicole and Prashida. We're back tomorrow morning at 9. We start at 9. if you got the link from a friend, please go on our website and go to the link and register, just so I can follow up with you and make sure you have access to all the materials from our conference. Anything else? I guess not. Have a super day. If you have to drive safely. It's wonderful to see all of you, and we'll see you hopefully tomorrow morning. Bye, everyone. Thanks so much.